So again, this is a humongous team effort and represents kind of international collaboration that is really unheard of. And it's one of the bonuses of COVID, I think, is the fact that people are doing things that they wouldn't normally do. Long may it last. So the hypothesis is that hospitalized patients with confirmed COVID, therapeutic anticoagulation safely improves clinical outcomes. So there are three big trials, the ATTACK trial, which I'm also involved in, and REMAP-CAP, which you're very familiar with. REMAP-CAP is the one that's mainly critically ill, but thanks to your help, we've managed to bring it into the ward as well. And then ACTIV-4A is the American one that's NIH funded, and they've all been working together. So essentially, there's a very sort of complex arrangement, but they have very aligned protocols. They have many shared individuals like me. They have the same statistician and the same outcomes. So the whole goal has been to answer the most important clinically relevant questions as quick as possible. So yes, that's basically said. We've also had combined superiority and futility stopping rules for the trial. So these are randomized, open label, adaptive Bayesian trial. Adults hospitalized for COVID-19, signs and symptoms consistent with COVID-19, and randomized within 72 hours of admission or 48 hours if you're in ICU. And the intervention for the therapeutic arm is basically heparin at acute VTE doses, either with low molecular heparin or an unfractionated heparin infusion. The control arm is a bit more of a mixed bag because it's usual care pharmacological VTE thromboprophylaxis, which could be up to intermediate dose. And so I'll explain why there's still unanswered questions from the data we have. So the duration of therapy was for 14 days or until hospital discharge, whichever was first. Primary outcome. Now this is one where as hematologists, we need to move away from our standard mindset of a VTE prevention trial, because we understand in COVID that there's a lot of clots that are measured, but there's also a massive burden of thrombosis that is unmeasured, microvascular thrombosis that contributes to organ dysfunction, and the kind of thrombotic complications in the lungs that is often not sort of measured. So essentially, you have to have a global outcome measure as your primary outcome for a trial in COVID, not a kind of VT event rate. And it's essentially an ordinal scale, but it looks at organ support free days. And it's a sort of composite of clinically relevant morbidity and mortality. So, I mean, for example, there's no point in preventing VTE if everybody dies of respiratory failure, if that makes sense. Safety, major hemorrhages and HIT, and efficacy, there's kind of other ones, including major thrombosis, arterial events. So we kind of have this two separate groups of COVID patients. The severe state are patients who are in ICU receiving organ support. So that can be CPAP, it can be high flow nasal oxygen. The moderate state patients are what you would visualize would normally go into recovery. So those are hospitalized, but not requiring ICU level care. And then there was also, for the moderate patients, a further sort of stratification according to baseline D-dimer results. And many of us have been extremely anti all those protocols that came in where anticoagulation has been dosed according to D-dimer. I don't know if any of you saw the BSH debate that Mike Lafan and myself did, but essentially that was not based on any evidence. So it's good to have properly tested this. So what I can say is there are very robust, quite stringent stopping criteria for different arms in these trials. So essentially you have to have reached a very high level of certainty for kind of an arm to close. And the decisions were separately made for severe and moderate, and for moderate for high and low D-dimer. Okay, so for the moderate state, all 3 platform DSMBs met and reviewed the data and recommended stopping for the pre-specified superiority statistical trigger, which means therapeutic anticoagulation is better than standard care. And that was in both of the D-dimer groups. For the severe state, the DSMB met earlier because it recruited quicker and was predominantly REMAP-CAP UK patients, to be honest. And this concluded futility, so stop because of futility. And actually there was a high likelihood of inferiority. So therapeutic heparin is not a good thing in patients who are have it initiated in intensive care. So these are the kind of trial numbers, and they're decent numbers of patients. So essentially the second group, the known overall organ survival free days, or whatever it is. Anyway, there's less patients in that because you have to have 21-day follow-up. So those are the patients that were included in the interim analysis. For the final analysis, it will be the patients randomized, so who have had the final follow-up. Hope that makes sense. So there's a good spread of ages and sex. I think you'll find, including quite a few elderly patients. And this is the key outcome for the moderate patients. So essentially, if you have an odds ratio greater than 1, then it's beneficial, whereas less than 1, it's not beneficial. And as you know, if your confidence interval doesn't cross 1, then it's significant. So for low and high D-dimer and missing D-dimer, it was equally beneficial. For the severe state, so that's the ICU patients, it was futile and actually high probability of inferiority. So this is just another way of showing organ support free days and just showing, so we've got the high D-dimer moderate state at the top here, a low D-dimer moderate state, and then we got the missing D-dimer group in the severe state. And essentially, the more red you are, the more kind of death and destruction, whereas the more blue is kind of patients who haven't needed organs support at all for their 21-day follow-up. Hope that makes sense. So this is mortality, and it's not a primary outcome, but I think with many of these studies, so all the COVID studies, it can help orientate you to think, does it matter or not? And if it follows the primary outcome, it does suggest it adds support to the weight of the study. So for the moderate state, where therapeutic anticoagulation, there was absolute risk reduction of 2%. It's not significant because it's not powered to look at mortality. For the severe state, there was an absolute increase in about 3% of mortality. So it's very much following the primary outcome, which is kind of, it's helpful. So it was Keith Gomez that asked me, so what's the number needed to treat? And I said, well, it must be treating 50 to prevent 1 death. I don't know if that's the correct calculation. But okay, so the thrombotic events, so absolutely what you would expect from a trial looking at anticoagulation. There's a reduction in thrombotic events, both in the moderate and the severe state. So this is a classic thing where in the severe state, we've got a lovely reduction in thrombotic events with therapeutic anticoagulation, but an increase in mortality, which just proves that wasn't the correct outcome measure. So conclusion, in moderate state, therapeutic dose is superior to usual care, and basically D-dimers don't help define what treatment people should get. Major bleeding rate is less than 2% on therapeutic anticoagulation. Did we miss the major bleeding data? Oh, there we are. Major bleeding, again, as you'd expect. It's higher with therapeutic anticoagulation, but actually less than many of the kind of retrospective observational data that was coming through for COVID. Okay. So for the severe state, therapeutic heparin doesn't improve things and is actually likely to be harmful. So there's still a big uncertainty. So patients who were recruited in the moderate state and then progressed to the severe, the protocols continued therapeutic anticoagulation, whereas for the severe state analysis, the patients initiated therapeutic anticoagulation in ICU. So there's still an uncertainty what to do if someone started therapeutic anticoagulation on the ward and then they progressed to severe. And so there's lots of interest into why the effects may be in the opposite direction for ward patients and severe patients. It's possible that timing of intervention really matters. And by the time you get to ITU, it's too late. The lungs are so full of very inflamed vessels that potentially vascular integrity could be compromised, which can result in alveolar hemorrhage, which has been seen in postmortems. I think importantly, the standard of care for most of the ward patients was just conventional low dose, but for the severe cohort, because they were mainly recruited in the UK, it was predominantly intermediate dose. And it's possible that, you know, there is a kind of optimal dose, a bit like with warfarin and a target INR of 2 to 3, that prevents clots, and further dose increases add risks without benefit. So Mike Macris tweeted that he thought it was due to unfractionated heparin infusions. Having seen the data spreadsheet, I don't think that's the case, because actually there were very few that had unfractionated heparin infusions. And there's one ICU consultant that said, well, obviously patients on therapeutic heparin, they may have had delays in, you know, essential life-changing interventions, whether it's tracheostomies or whatever they needed. Who knows? I guess the other thing just to say is that the standard of care thromboprophylaxis is quite controversial. So there's been plentiful guidelines published based on expert opinion, a bit of observational data, and the whole result is that they're heterogeneous in their recommendation, particularly for the severe COVID cohort. So many of the European and UK guidelines have recommended intermediate dose for this cohort, whereas the kind of more international guidelines and the American guidelines have said to stick with conventional low dose. So the big ongoing unanswered questions is the role of intermediate dose heparin. The antiplatelet domain, I'm delighted, has recruited well over 1,000 patients. So I think we should be reaching an answer soon, just within REMAP-CAP. And then we've also don't quite know what to do with patients who progress from moderate to severe if they've started therapeutic anticoagulation on already. People like me, you know, having seen things like Bechet's, where actually anticoagulation has limited efficacy, but immunomodulation is the strategy to ameliorate risk. COVID-19 may well be the same. And so we're very interested to look at the interaction with things like tocilizumab. So just this is my last slide, I think, just to say that we're amending the anticoagulant domain. And this will be very much led by the UK, and this will be just for the ICU patients. And we will be looking at conventional low dose versus intermediate dose heparin. And then for patients who've already started on anticoagulation on the ward, they'll be randomized to continue or de-escalate.
Charlotte, can I ask you a question, please?
Yes.
I work at Leicester, and we're currently rewriting our COVID heparin guidelines for, I don't know what number time now. I'm interested to know what you're doing and whether you're putting this data from REMAP-CAP into your guidelines.
This is a really interesting question, and actually I'd already had various email conversations, including with people like Jill and Lara who have been on the call. But essentially, the interim data I really trust because I know the trial and I know how stringent the stopping rules are, the fact that all 3 trials had outcomes in the same direction. So it's not like there's sort of one that's being wacky out of keeping with the other. But there is now a very strange kind of hiatus where there's a lot of the world, including the UK, that feels they don't want to change anything until they have published data or some kind of national guidance. And so the problem is that both those things could take 2 months. And in the meantime, you know, many centres, including ours, have got a tsunami of COVID admissions that potentially might be benefiting. So there have been different approaches. So there are some hospitals that are adopting this early. I think some key things to really think about is ensuring a robust bleeding risk assessment, bearing in mind it'll be sort of overwhelmed F1s admitting patients. And so it won't necessarily be the same, you know, robust process as recruiting to a trial. So I can send you the kind of the trial exclusion and entry criteria if that kind of helps. The other concern from our centre was kind of making sure it's really clear about this whole moderate and severe and the patients that fluctuate between the both, and just making a safe protocol. So I was very keen that we did try and escalate anticoagulation at the front line for our hospital, but we're currently holding off. Quite a few of us hopefully will be contributing to a kind of national guideline statement, but it will be weeks. So I think if places like Leicester are kind of ready to go for it, you know, I think that's a really reasonable thing to do. You know, there will be other hospitals that take an old-fashioned approach. We have to wait for the full publication. The problem is that COVID isn't a normal condition. So, you know, there's no right answer.
Yeah, I think that's exactly our problem. We feel like this would be the right decision to do, to go with it without the published data, because the numbers are high now and we could potentially make the difference now. But it's just that staring off the edge of the cliff, not quite wanting to jump, if you know what I mean.
I feel really uncomfortable not doing anything now that we have that data, particularly as all the guidelines all our hospitals have written were based on no evidence at all. And we now have evidence. So it makes it really hard not to do something with it. But I also understand the kind of the fear on the front line, you know, and it's not like hematology admissions where you can watch them every day, check their blood results, keep an eye on them. You know, these are medical admissions. It's a bit like a battleground there, and just ensuring it's safe. So at the moment, it's really unsatisfactory as to what's the right direction to go in. But I feel more uncomfortable not doing something than doing something, but many people feel differently to that. But that's partly because I know the trial and I trust it. And, you know, all the other interims have been correct. And the final analysis will be slightly different, but it, you know, you can bet your bottom dollar it won't be in a different direction. It'll be slightly different rates of bleeding, thrombosis, you know, slightly different OR. Sorry.
Thank you, that's brilliant.
Answer, but it's essentially a really difficult question.
Yeah.
And I don't know the right answer. And I think whatever you do, you know, you will be doing something right and something that someone else is doing in the country.
Thank you.
There's a question, Charlotte, from Andrew Doyle, from King's in South Thames, is about in the chat. I don't know if you can see that, but essentially saying, was there a signal in the data that suggests when we should be stepping down from treatment to standard dose thromboprophylaxis in the moderate patients?
Yeah, so in the moderate patients, this is for patients getting better. So essentially what we said was they either had 14 days or until discharge, whichever was soonest. And then after that, it was at the clinician's discretion what treatment they should have. So most of us have not grasped extended thromboprophylaxis for COVID patients, because actually the data suggests that post-discharge rates are actually really low and bleeding rates are still significant. So you're probably doing more harm than good. So I think if someone's well enough to go home and is otherwise mobile and has, no other risk factors, they haven't been to ICU, I would stop at discharge. Basically, you won't go wrong if you follow what was done in the trial.